Welcome to Access Amplified, the podcast where we shine a light on how digital health is increasing access to care and advancing equity around the world. I'm your host, Joanna Braunold, and our podcast is brought to you by Taito Care. In each episode, we sit down with healthcare leaders who are doing the work, not just reimagining access, but building it from the ground up. Today, we're diving into a powerful model that's redefining what care can look like for children, not in clinics or hospitals, but in schools. Our guest is Dr. John Jenkins, the Medical Director of School-Based Care at Cone Health, where he leads one of the most forward-thinking telehealth programs in the country. Dr. Jenkins has been bringing digital care into Title I elementary schools across North Carolina, using telehealth to reduce absenteeism, cut down on unnecessary ER visits, and build trusted relationships between healthcare providers, schools, and families. Today, he's going to share with us his vision and practical insights to how we care for kids, starting with where they are. Let's get started. Thank you so much for joining me here today, Dr. Jenkins.
Very glad to join.
Let's get started with your own journey. What led you into digital health, and how did that evolve into a focus on school-based care?
As a practicing internist for about 23 years, I had the opportunity about a decade ago to get involved in shaping the way we deliver care, and was invited by our then CEO, Tim Rice, to become a physician leader. My journey was one of which I had the opportunity to kind of select where I would have an impact on the healthcare system. And I chose process improvement using lean methodology to change the way we look at delivery of care and make it more effective, more efficient, more consumer focused. On that journey, of course, digital health became a very prominent part of how we could do least waste delivery of healthcare. We started a program that was asynchronous store and forward technology called e-visits, and then we had a virtual visit program as well. That led us to really looking at other opportunities for communicating with our patients in a direct way that really made it convenient for them to access care. Of course, we had the episode that we lovingly call COVID-19, which changed the whole game. And during that period of time, we spent a lot of time working with safety net practices and practices getting online. Towards the end of COVID-19, we had a grant from the Duke Endowment to prototype school-based telehealth. People didn't think we could get it started during COVID, but we were able to. And we had a prototype at an elementary school that was just coming back to in-person learning. The students were still wearing masks, but we were able to start access to healthcare and screening so that every student who had a runny nose didn't get sent home because they thought they had COVID. It was a wonderful experience, an experience in which we got trust of educators and trust of parents and trust of the family, and the school-based telehealth program took off. Today, we're in 26 schools in Guilford County. Next year, we will be in 36 schools in Guilford County. We have a full-time telepresenter in each school, and now we're in 2 additional counties. And it's been a journey in which I must say, I don't think I've had a job where I looked more forward to coming to work.
That's the dream. And I have to say, starting a telehealth program in schools during COVID is definitely an adventure. Can you walk us through how that school-based, and I assume it's developed over time, but can you walk us through today how that school-based model works day to day?
Yes. So the uniqueness of our program is that we have a full-time telepresenter in each school who is there when the school starts in the morning at 7 a.m. and doesn't leave until the buses arrive at 2:30 to take the elementary school students home. We're exclusively in elementary schools because we believe that telehealth is adaptable to the needs of elementary school students better than middle school or high school as a single source of care.
Okay.
And we are unique in that in our partnership with the school provides us a HIPAA-compliant space where the students can be referred from the classroom by a teacher, can refer to any member of the school staff, and then if they are consented, we proceed to a telehealth visit with a provider. We use modern technology, which has really revolutionized the ability to examine a child remotely. Our providers are all remote. And using that technology, we're able to actually look in the ears, eyes, nose, and throat, listen to the heart and lungs. And the telepresenter also augments that by being the hands of the provider. So the providers have done special training with our telepresenters to help them to percuss and to palpate and to push on that abdomen and see where that tenderness is, to be able to touch to see if that lymph node, that tenderness is actually a lymph node, and to be able to focus on an area of rash or an area of a hair follicle that might have a creepy crawler critter on it, to be able to take those images so that we can make the diagnosis. That relationship continues to grow. Not only do we do provider-based care, but we uniquely have a relationship with our public health nurses to do collaborative delegated visits. So
Okay.
our public health nurses are responsible for all of the chronic care that occurs in our schools. Doctors write standing orders, they create a care plan, and they handle the asthmatics, they handle the diabetics, the seizure disorders, children who have to have medications administered in school. Unfortunately, in our districts, we don't have a school nurse there every day, so those services have to be delegated. So we have a unique partnership with them to participate with a school nurse in that partnership of delegated care. That allows us to return even more students to the classroom who perhaps aren't consented for provider-based care, but they are part of the school system for a delegated care.
Okay.
So the program continues to grow. Our program now has added some components to it that really are focused on this idea of reducing chronic absenteeism. One of them is we have several medications that are available for the provider to prescribe or to give an order for. So we can give Tylenol, Advil, Zyrtec, anti-nausea medications, certain topical creams that would allow the child to stay in school rather than have to leave school to get a Tylenol. And this has been very effective. Next year, we're adding point of care testing for COVID, again, full circle, because it's still out there, influenza A and B, strep, and RSV, that will allow us to advise the parent and the school as to who can go back to classroom. They have a negative test. That runny nose has nothing to do with an infectious process. Or as a positive test, need to go home, and how long do they need to go home? This advice has not been readily available for schools without point of care testing.
Right.
Also, excitingly, next year, we're adding, using our virtual platform, we're adding behavioral assessments and therapy. Again, our focus has been on keeping children in school, addressing this chronic absenteeism. When a child has a behavioral health need and has to leave school because they've been referred outside to a provider, that's an entire day of lost school. It's disruptive to the class, it's disruptive to the child, it's disruptive to the family. You have to take off work and take them to that provider. By using or leveraging telehealth to connect our licensed social workers, clinical social workers, to be able to do the assessments in the school and be able to provide therapy in the school, has been a really exciting innovation that we think will, again, help us to address absenteeism as well as the needs of our students for behavioral health therapy. We do that in partnership with the schools' existing programs. We help with their wait lists. We help with schools where there are more students who need care than an in-person therapist as a part of the school system can handle. And so it's truly a partnership to address these students' needs.
And I'm assuming that at least some of the time, those schools are going to be the ones who are going to be referring the kids for their behavioral health needs anyway. So by addressing that within the school, you're keeping it in the family, so to speak.
So it's a partnership. Most schools have an assessment process by which the teacher recognizes a student has a behavioral health need. There is an assessment team that says, what does that child need? Do they need some classroom activity, some after school activity, some special skills, coping skills, other skills to be taught through the school's infrastructure? And then when they filter it down and recognize that the child has an assessment that is required to really look for the root cause of their behavioral issue, and then therapeutic interventions. We've also, Joanna, got something that I think is going to revolutionize some of this because the schools don't have the opportunity to do this. So the grants that we have written to be able to provide this service, we've included community care workers. When we identify a trauma that a child's experiencing, the community care workers can actually work to help families access resources to address these trauma events. Maybe the trauma event is housing insecurity. They're moving housing. They lost their house. They had to move to someplace else. Maybe they're living in a car. It's food insecurity. Maybe there are other social determinants that are occurring that we can help them with. Maybe they don't have a bed. All these things affect children in a way that they may act out. They may have behavioral issues. And just giving them coping skills and therapeutic sessions doesn't address those root causes.
Right. Absolutely. I think that sounds like an amazing opportunity to take that kind of whole family approach and get to the root cause. And it kind of leads me on to my next question, because I think the impact that you're having on the children, but also on the wider families, is significant. And you have said previously that access and equity are not the same. So what have you learned about creating equitable care and not just access to care through schools?
Sure. So one of the ways that I like to think about equity is that you reach people where they are in the way they want to be reached. So we have a great part of our society who cannot reach the care they need. It's not an access problem. It's an ability to see where it is and ability to understand how to utilize it. By taking that from an equity approach, we bring the care to the families where they are in trusted sites that they can access that care without disruption to their daily lives, and also overcoming barriers that they have that are created by the social determinants in their lives. Many people have transportation issues. And so if we provide care at a hospital or a clinic, they can't reach that. It's not equitable to them. There are other times that they have financial barriers. A specialty copay to receive behavioral health is a significant barrier that they cannot access. That barrier may be cultural. They may have a trust issue. We have many newcomers in our environment right now who are afraid in some instances, and accessing institutions are difficult for them.
Yeah.
So having the care in the school where children are placed by families who have a great deal of trust allows an equitable distribution of services to these families.
And I think that's something that I also wanted to talk about, because one of the things that you have done really well when I've spoken with you in the past about your programs is bringing those parents into the process, especially in those cases where there might be trust barriers. Obviously, leveraging a school, which is already a trusted place, is a start. What else are you doing to bring those parents in, to bring the families in a way that they feel confident?
So part of the secret of our program, and I guess I'm letting it out of the bag so it's no longer a secret, is that our telepresenters are trained CMAs, and they are demographically similar to the populations we serve. We attempt to recruit CMAs who can speak Spanish.
Okay.
We attempt to recruit students who, CMAs, excuse me, who are representative of the populations we serve. So if we have a school that is primarily African American, we would like to place a African American CMA there. So that creates a trust, because to those children and to those populations, our telepresenters are like them. They look
Right.
like them. They recognize them as being someone who they can relate to. So that's step number one. Step number two is we involve ourselves in the fabric of the school. We go to the parent nights. We go to the school activities. We encourage our CMAs to integrate into the school as a part of the school staff. We work with the school system so that our CMAs have Guilford County Schools email addresses so they can contact directly with the school, with the teachers. We encourage them, if they have downtime, to go to the classrooms and visit so that the teachers and students see them as part of the whole network of the school. And I think this is really critical, that we're not the hospital in an isolated space with a sign on the door that when you go through the door, you're at Cone Health. We are in the school.
Instead of standing out, you're part of the system that they're already within. And you do all the training for your CMAs as well, right? From what I recall.
So I'm blessed with a great team. I have an operations manager. I have an RN clinical director. I have a program director, and we have a detailed CMA manual that includes all of the pathways to help them, or we're continuously improving, so I shouldn't say all, the current pathways to help them to provide reliable care to the students. They're trained on the technology and the devices. They're trained on Epic so that they can assist in documentation and scheduling for the visits. And all of this training, we spend anywhere from 4 to 6 weeks at the beginning of their employment, and we have various refreshers during their employment to be able to make sure that these skills continue. Our clinical director has a responsibility to sign off on competencies every year to make sure that they know exactly how to do things. And then we have this great relationship with our public health nurses for the delegated care, where they can talk together about students who may need additional services that are beyond the scope of just a visit. They may need a referral to a medical home because they don't have, that family has not established that relationship to get those well child visits, to get those immunizations. They may need other community support services that the social worker can help us to do it. It might be as simple as they need to learn how to get onto Medicaid, and then to get onto the CHIPS program so that they can have nutrition and insurance.
That, I think, kind of leads us into what you describe as a whole child model. How are you thinking beyond, I mean, you've kind of already pulled out some of the examples, but how are you thinking beyond just, acute care? What does that look like in practice? And what's, you mentioned helping them get onto Medicaid, perhaps. Are there other kind of broader services that are included within that are helping to improve the family's well-being?
That's a great question. Thanks for that, John. I think that is the key to our mission as we move forward in school-based telehealth and other school interventions that address chronic absenteeism. I was recently in Washington, D.C. at the Johns Hopkins Center for Public Health. They have a Center for School Health within that program. There was a call to bring together people from across the United States to address the concept that chronic absenteeism in our school is a public health urgency. It is something we need to focus on. And there was unity of belief that this call to action was critical when we look at chronic absenteeism being present in 1 in 4 elementary school students.
Wow.
1 in 4.
Wow.
That means 1 in 4 is missing over 10% of their educational opportunities in schools, in many cases much more than 10%. And that's impacting their ability to achieve what is their full potential in the school. Health delivery within the school system that helps to keep children in school, whether it's physical health or mental health, is a part of a community of services that have to be seamlessly brought together. So we have our school nursing services. We have our social work services. We have community services that we have to connect families to. We have behavioral health services. We have physical health services. All of this becomes an ecosystem in a school to make it a healthy school. The CDC has a model on their website that talks about healthy schools. And I think that model is very descriptive if you look at it when it's surrounded by perhaps there's activities. That's part of keeping a child healthy, getting them to exercise, getting them to play. So that's a part of the program, making sure that they have access to what they need to learn, eyeglasses, dental care. These are crucial issues that affect a child's experience at school. If a child can't stay in school because he's sick, or doesn't want to go to school because he feels bad, or doesn't want to go to school because he's not being engaged, These are all things that we have to address together. So we're not the solution. We are a part of the solution. And it's critical that we be a partner 100% with our school, with our superintendents, with our principals in delivering what we do to make sure that we integrate that into a whole child, whole school.
I love that because I think that's, a lot of what you were saying. Typically we would say, well, that's the teacher's job or that's the superintendent's job. But taking this approach of addressing the whole child and taking a look at what, if there are issues, what's the root cause of them? How can we solve them? That's not just something that's going to happen in the classroom, although of course the teachers and the school are a part of that as well. But that's something that's going to happen in the home, in the healthcare space, in food. You were speaking before about, all of these different angles. And so I love this idea of kind of bringing all of this together to give kids that access that they need to learn. And you've just spoken a lot about absenteeism. Let's talk numbers. What impact have you seen on absenteeism and learning outcomes when care happens in the school building?
Surely. So we have a system with our school partners by which we identify each of our students who participates in our plan and links that to Infinus Campus for their database. So then the school can analyze and see exactly what impact this has on the individual student's life. When you look at absenteeism before they engaged in the program and absenteeism after they engaged in the program and see a reduction. Remarkably, we've seen a reduction in the vast majority of the schools that we
Oh.
see. It's a multifactorial thing. We're not the only effort that's in place to reduce chronic absenteeism. We're one of them, but we want to see that kind of collaborative impact. We've also seen some end of year scores improve in, again, the majority of the schools we're in. And interestingly, we've seen a huge drop in the students who are consented and participating in our program in behavioral incidences.
Wow.
And I think it is being able to have that additional point of care with the children for them to understand that they are important and that they are being cared for in the school environment, and to help to address some of the issues that are causing those behavioral outbursts. So that's been very effective. We are instituting some new ideas all the time. That's part of our process. One of the new ideas is brought to us by our partner. Cone Health recently became part of Risent.
Okay.
Risent is a value-based program to align organizations who are interested in value-based care, and it's part of the Kaiser Permanente system. Kaiser has a wonderful program in the West Coast called Vibrant Schools, and they actually were a sponsor of the program at Johns Hopkins for addressing absenteeism as
Okay.
a national outreach. One of the things that we are doing together is finding out a way to take the data we get in the school about chronically absent children and getting that down to the primary care.
Okay.
Wouldn't it be wonderful if a pediatrician could see on the problem list that the child they're seeing for a well child visit was chronically absent, and then be able to address with the parent or the family member who was there in that visit, what are the barriers that are existing in your lives that are causing this absenteeism?
Uh-huh.
Is it transportation? Is it insecurities? Is it that the child has separation anxieties? So that they can help also to see what we see in the school environment, to see outside of the school environment, and create a better network of care for the family. I'm excited about that potential.
That's very cool. I guess I wonder what will happen. Some of the kids, I would imagine, certainly don't necessarily do those wellness visits or don't have access to that primary care physician. So, is that to an extent creating a cycle where those who do have that will end up being flagged better? Like, how do we also still address those that don't go to those wellness visits?
So part of our program initiative for next year is to identify students who do not have an active medical home
Okay.
Maybe they've listed a primary care doctor, but the last time they saw him was 2 years ago, not an active medical home, and helping them to get back into their medical home. We are providing urgent on-demand services. We are not primary care within the school. So we want to partner with our community. Part of our initiative also is to identify those students without medical homes and make referrals. So we're reaching out to our community, to our safety net practices, to our cone health practices, and finding out what practices have availabilities so that we can make these referrals for the children to be able to see a primary care provider. We're also having discussions about, hey, if you don't have hours that are outside of school, you're contributing to chronic absenteeism. So we're encouraging practices to look at access points that are after school hours, that are on Saturday, so that we can see children in a way that's not disruptive to their education.
That's great. Thank you. I want to kind of wrap it up with a question for you. Because you've been working on school health programs for a while, you've been at Cone for a while, and you've shared with us your journey. What keeps you inspired, and what is the thing that you're most proud of at the moment that you're working on?
So the people that I work with keep me inspired. The wonderful CMA telepresenters who are in the school, who share the stories of impact. We recently heard a story from one of our telepresenters where a child who was an asthmatic presented, and we have the ability to use a pulse ox. The SATs were dropping rapidly, so it was an urgent situation. We couldn't get a hold of their parent to transport them to the hospital. And our CMA called up and said, Dr. Jenkins, can I leave my clinic and get in the ambulance and go with this child? And of course, the answer was yes. And so, because the ambulance wouldn't transport the child without a
Without an
responsible
adult.
being identified. So, these sorts of things, I think, give me my biggest reward. The fact that we've been able to network talented, well-trained CMAs who are part of the school, connecting them with nurse practitioners who are passionate about their work, partnering with school principals and teachers and guidance counselors who see the value of our program. And then we recently have begun to survey our parents as to say, do you see this as high value? And they are telling us that they see this program as high value. That's the reward.
Yeah.
Having an
That's
impact on the community, and we're providing something that people feel like they need. And that's what gets me up every day and gets me into the office.
And that is an impressive goal to have achieved. Thank you so much. That's it for this episode of Access Amplified. A huge thank you to you, Dr. Jenkins, for sharing such powerful insights into what it takes to build equity inside our schools, and for reminding us that when we meet kids where they are, we not only provide ourselves with work that makes us feel satisfied, but we also create healthier futures for our entire communities. If you enjoyed today's conversation, be sure to follow or subscribe wherever you get your podcasts. Please share this episode with a colleague who's passionate about digital health, access, or rethinking care delivery. Access Amplified is brought to you by Taito Care. I'm Joanna Braunold. Thank you so much for listening, and we'll see you next time.